to discuss today, and see if and discuss the open ends that still needs to be investigated. So what we already know on inspiratory muscle training in mechanically ventilated patients is, first of all, that we that the best option is that we only perform it in cooperative patients, because uncooperative patients, we cannot ask them to do deep breaths in to perform actually a qualitative good training, and also providing an inspiratory loading while patients are uncooperative can be quite can induce anxiety as well for these patients. So that's why we say that only use it in cooperative critically ill patients. We know that it's safe and feasible to do in these patients, and that we can improve the maximal inspiratory muscle strength. What we're not sure about, but there are some indications, is that we can reduce the duration of mechanical ventilation. We might be able to reduce the weaning duration, the ICU length of stay, and the ICU mortality rate can maybe also reduce. However, studies currently are showing quite contradicting findings, and this is mostly due to low methodological quality in the studies. Many of the studies use the control group instead of a sham intervention, which would increase the quality of the study. So the next steps to do are, we need to try to optimize the inspiratory muscle training protocol and maybe also use a sham intervention. So that's what we did. And we also tried to find some answers to some questions that we had along the way during our studies. So I will go over these open ends that we had. So first of all, we were wondering what type of loading or device should we actually use in critically ill patients. So yeah, we could use a pressure threshold loading or maybe a tape flow resistive loading, which are the most commonly used devices. The tape flow resistive loading, an advantage that it has above the pressure threshold loading, is that we have visual feedback during the training, which makes it much easier for the clinician to actually provide targeted feedback during the training. And also the patient can actually see their progress, which also boosts their motivation for the training. It's not only the feedback that is important, the important difference between the devices, but also the type of loading may induce differences in training responses. So first of all, here you see the PI max, so the maximal inspiratory muscle strength that we can generate over different lung volumes. So when we are at residual volume, we can generate the highest negative pressure, so the highest strength we can generate at residual volume. And while we breathe in, we will increase our lung volume, but our strength capacity will also decrease until it's almost zero when we reach total lung capacity. And so when we use a threshold loading, which is a loading that is constant, when we set the load to 50% PI max, it will stay at 50% PI max. And we breathe in, at a certain point, we will not be able to overcome the same loading anymore because our capacity of the respiratory muscles have decreased. And so the valve will close, it will shut down, and we will not be able to breathe in any deeper. While if we use a tape flow resistive loading, the loading will actually decrease throughout the inspiration. So even though we put it at the same resistance at the beginning, the loading will decrease during the inspiration and patients will be able to reach higher lung volumes. And this is important because training over a larger range of lung volumes, it can result in the fact that patients will be able to also train their respiratory muscles at these higher lung volumes, which is important during, for instance, exercise, or when they are more dyspneic, they will be breathing at higher lung volumes. So in order to overcome these barriers, it's really good that we can train at higher lung volumes. And also the tape flow resistive loading not only ensures that we can breathe in deeper during the training, but also at a faster inspiratory flow rate. And faster inspiratory flow rate means that we can generate more power and that the training will also be more qualitative. So based on this study that we did, we said, okay, let's use a tape flow resistive loading, as this will probably result in a higher benefit for our patients. Then the use of a sham intervention. We did that in a large randomized controlled trial in which we included 90 patients with weaning difficulties, of which half were randomized in the intervention group, and they received high-intensity inspiratory muscle training, and half were randomized in the sham group, which received low-intensity inspiratory muscle training. Both trained with the tape flow resistive loading on a daily basis, but the difference was in the set resistance. Patients were training at about 30 to 50% of the maximal inspiratory muscle strength, and we tried to increase the resistance on a daily basis. And we did 4 sets of 6 to 10 fully vital capacity inspiration with fast inspirations. While the control group, they trained at less than 10% of their maximal inspiratory muscle strength. So in practice, this is at 3 centimeters of water, because that's the lowest resistance that the tape flow resistive loading can provide. And we did 4 sets of 6 to 10 full vital capacity inspirations. So how many patients with weaning failure are eligible for IMT? Just you can have a moment to think about it, but do you think that more than 75% of the patients are eligible? Between 50 to 75%, 25 to 50, or less than 25%? It might be unexpected, but actually less than 25% of patients who have weaning failure are eligible for inspiratory muscle training. And this is not something that only we found, but also Bernie Bisset and Timothy Jenkins also found this in their studies. And the most common reasons are that patients are hemodynamic unstable or respiratory unstable, which is quite logical in our populations that this is a barrier. But actually, the majority of the patients were not able to follow simple verbal instructions related to inspiratory muscle training. So that's mostly due to sedation use. And that's something that now also is a hot topic on the ICU, is trying to reduce the sedation use so that patients are more adequate. And so hopefully in the future also this number will go up and we will be able to train more patients with inspiratory muscle training. However, even though it's a small percentage that we can help, it's still very important that we think about inspiratory muscle training, because we can improve their respiratory muscle strength, which is very low in these patients. The majority only has an inspiratory muscle strength of about 30% of their normal, what they should have had if they were not diseased. So, not ill, I mean. Then, of course, what is the effect on inspiratory, on weaning? What is the effect of IMT on weaning? If you look at these 3 studies, we see actually clear effects. We see that the weaning success rate is significantly higher in the intervention group compared to a control group. The control group here got usual care, and actually Martin used also a sham intervention. So the last study, the red one, also used a sham intervention where they also saw a significantly higher weaning success rate in the intervention group. However, then more recent studies that were performed with the tape flow resistive loading did not see the same clear benefits. So we saw actually the same weaning success rates in the intervention group, but here we have 2 out of the 3 studies that actually had a much higher weaning success rate in their control group, which was quite unexpected. And same for our study that we did, the randomized controlled trial, in which we also compared to a sham intervention and we used the tape floor resistive loading. We found that there was no significant difference in weaning success rates. So as you can see, our weaning success rate was similar to the other studies in the intervention group, but again, much higher in our control group, which we did not expect, of course. We also looked at the effect of inspiratory muscle training on inspiratory muscle strength in patients in studies that included patients with known weaning difficulties. And so here we see that in the intervention group, in previous studies, there was an average increase of 12 centimeters of water in the intervention group, while there was an increase of 7 centimeters of water in the control group. For our study, again, surprisingly, we had really high improvements in our control group. Our intervention group was again similar to other studies, but the control group did much better, actually doubled the improvement in the respiratory muscle strength compared to the previous studies. We did, however, see a significant difference in improvement in forced vital capacity. However, if you look at the values, we are talking about 150 milliliters of improvement compared to the sham intervention. And we also looked at the oxygenation of the scalene and the sternocleidomastoid muscles, so two muscles that are also respiratory muscles. The sternocleidomastoid muscle is more of a muscle that is only used in as an accessory muscle. So when we're doing high intensity training, for instance, we will also use the sternocleidomastoid muscle, while the scalene will be also used during rest. And we saw that for the scalene, there was no difference in oxygenation pre and post the intervention between the two groups, which means that that the scalene actually improved in both groups equally, so that it became more efficient. It needed to it used less oxygen for the same power output. However, the sternocleidomastoid muscle became much more efficient with the high intensity inspiratory muscle training. So with the high intensity group, we were able to increase vital capacity and oxygenation of the sternocleidomastoid, but we had similar improvements in the scalene oxygenation. So of course, with these results, we started to think, did we actually train the patients of the sham group? Because we had high improvements in PI max, and we had also similar weaning outcomes. And the third thing is that we also had high symptom scores during IMT in the sham group. So we actually based the progression of the training in the intervention group based on the Borg score for respiratory effort and dyspnea. So if patients reported in the intervention group a Borg score between 4 and 6 out of 10, we said that this was a good resistance, that it's not too high and not too low. However, in the sham group, we just asked the Borg scores, but we did not adjust the resistance based on that. And so surprisingly, we actually saw that they also reported a quite high symptom scores, certainly at the beginning of the training intervention. At the end, it became a bit less, but still 3 out of 10 is still quite high symptom scores for such a low external resistance. So we started to think, okay, what load intensity should we actually use and how should it be progressed? We were thinking, okay, should we use less than 30%, between 30 and 50%, more than 50%, or does it even matter? We were not sure. So we went into the literature, and unfortunately that did not make us any wiser, because here you see several studies that use different intensities, between 10% of the maximal insternal muscle strength until 50%. And then we plotted the increase in maximal insternal muscle strength of the intervention group compared to the usual care group. And you can see that there is no clear effect of the intensity that was used with the amount of increase in maximal inspiratory muscle strength. So based on this, we still did not know what intensity we should use. And because most of them just used usual care, we were unable to use those studies. But yeah, if a sham intervention was used, we could compare a low intensity versus a high intensity. And so there are two studies that we could base this on. The previous study of Martin, which also used a sham intervention, and then also our study, the ICU study. The intervention of these two studies were quite similar. So Martin trained 5 times a week, we trained 7 times a week. And the highest tolerable intensity was chosen for both in both studies. In Martin, it corresponded about 20% of the PI max at the beginning of the training period, and we started at about 33% of the PI max. And we asked to do forceful and fast inspirations. We then also used the tape flow resistive loading instead of the pressure threshold loading. For the control group, and so we also saw that our improvement in PI max was higher in the intervention group than the one of Martin in their study. But then in the control group, it's also quite similar, but the only difference is the instructions that we gave. So Martin actually asked patients to do long and slow inspirations in the sham group, while we actually asked them to do full vital capacity inspirations, so also quite fast and complete inspirations. So that was a difference in the sham group. So PI max in the intervention group, it improved significantly in the study of Martin compared to the sham intervention, while we had similar improvements in both groups. And also the weaning success was higher in the intervention group compared to the sham intervention, in the intervention group compared to the sham group in the study of Martin, while we also did not have any significant differences. So why did our sham group then actually improve similar to the high intensity IMT? That was what we started to wonder, because Martin actually did show a significant difference and we did not. We did a brainstorm session, and the first thing that came up was, okay, we actually provided different instructions in the sham group. So Martin did slow and deep inspirations, while we did fast and deep inspirations. And we also were thinking, okay, what is actually the total training load that we put on during the training for these patients? We have the external load, that is what we measured, that's the 33% that we put on. But these patients also have an increase in internal load because their respiratory system compliance is worsened. And so the internal load might also be is also part of the total load on the inspiratory muscle. So actually we do not know the complete loading that we put on during the training. So to investigate our hypothesis that these two could play a role, we did another study in which we investigated the inspiratory effort and respiratory muscle activation during different breathing conditions in patients with weaning difficulties. The conditions were first just during normal mechanical ventilation. Then we asked patients to breathe spontaneously for a minute. Then we had low intensity inspiratory muscle training with less than 10% of the PI max that they trained against. And we asked them to do slow and deep inspiration, so very similar to what Martin did in 2011. And we also asked them to do fast inspirations against this low intensity training, so comparable to our sham intervention. And then we had high intensity inspiratory muscle training, so with 30% of PI max with fast inspirations and deep inspirations, similar to the intervention of Martin and of our study. And during these conditions, we assessed pressures, so the airway pressure swings and the esophageal pressure swings, which characterizes the external load and the total load. And we also assessed with EMG the muscle activation of the scalene, sternocleidomastoid, and the parasternal intercostal muscles. So the external IMT load, yeah, it seems that it's actually just the tip of the iceberg, which I will explain here. But here you see that the total lung volume that patients could reach during the different conditions, yeah, we did not measure it during mechanical ventilation, but during spontaneous breathing, was lower compared to when we asked them to do deep inspirations, but slowly. And of course, when we asked patients to do deep inspiration and fast, we could actually also reach higher lung volumes and a higher flow rate, of course, which was similar. The volume that patients could reach was similar when they performed either with a low intensity or a high intensity, as long as they did the training fast. When we look at the external load, we see what we would expect. So the external load is what we set on the device. If we put a low load on the device, the loading will be lower compared to when we put on a high load. If you then look at the total load, we actually see something that we did not completely expect. And that, yeah, or now we did, but not at the beginning of the randomized control trial. That is actually that there is no longer a difference between the low load and the high load when we do it fast. So as long as we did it fast, the total load on the respiratory muscles was similar. Compared to when we did a low load and we asked patients to do the inspiration very slow, we did had a lower total load imposed on the muscles. So the total load is a total amount of work that they actually needed to do. So this actually explains why we did not see a difference in our randomized control trial and why Martin did see a difference, because Martin used this. And so the total load was lower, while we actually, unfortunately, provided a quite similar training for these patients. And this is also confirmed by similar responses in respiratory muscle activation. So respiratory muscle activation increased and was similar between the two last conditions. So as long as patients did a fast inspiration, they had higher activation of their respiratory muscles, and so also probably a better training outcome. So to conclude, we need to try to further optimize in-store muscle training. We know that tape flow resistive loading provides better and is better adapted to the respiratory muscles. If we can increase tidal volume with a similar external load intensity. So we can improve tidal volume and inspiratory flow rates, which will increase the load intensity. And we also have valuable biofeedback during the training. And we know that the external load that we put on the device is just the tip of the iceberg. It only accounts for 1/3 of the total inspiratory effort that the patient is actually doing. So the internal load accounts for 2/3 of the total inspiratory effort. If you provide low intensity or high intensity inspiratory muscle training, as long as you do it fast, it will provide you similar effects. However, if you ask patients to do slow inspirations, it's not the same as doing fast inspirations. So breathing instructions during inspiratory muscle training have a major impact in this population. If we do fast inspirations, we can increase tidal volume and inspiratory flow rates, and thereby also the total inspiratory effort. So the intensity progression, it should be based on tidal volume responses. If you have the tape flow resistive loading, you have the tidal volume responses on the laptop. And if you use the threshold loading, you can also only base it on the respiratory symptom score. So that's our two important parameters to take into account to try to increase the training resistance in this population. thank you for your attention. If there are any questions, I'm happy to answer.
Thank you, Maureen. That is certainly food for thought. And you've described your presentation, or your research, sorry, so well. I love the animals and the diagrams throughout. If anybody does have any questions, please feel free to put them in the chat. Can I just ask a couple of things that I wanted to find out? I guess my first question is, we're thinking about a patient cohort who are often incredibly unwell. They are on ICU, on mechanical ventilation. Or did you find any patients that were unable to even complete either less than 10% inspiratory muscle training load, or you talked about the high load to 30 to 50%? Was everybody able to complete these loads, or were there people that weren't even able to do that?
No, actually, so all the patients that we were able to include, based on their cooperation level and medical stability, they were able to perform the training. But that's another thing. These patients, they have such a low PI max. For instance, we had patients with a PI max of 20 centimeters of water or 30 centimeters of water, which means that 10% and 30% in absolute terms is actually quite low. And also the difference between 10 and 30 is almost negligible. There is almost no difference anymore. So we did choose to not put the resistance too high in the beginning. So 30% was high enough in the beginning, also that they could get used to doing the training. But they were able to do that. It's also good to remember that these patients in the beginning, they also have difficulties with just controlling their breathing. They haven't been able to breathe spontaneously for so long, sometimes months, that just controlling their breathing and being able to do a full inspiration and expiration on command is quite difficult. So that's something that indeed we had to work on in the beginning, and was a limitation to increase the resistance. But even this moments of just learning how to rebreathe, it helps them to improve even the PI max.
You've started to touch on the topics of a few questions that have come through, and one of them is actually one that I was also going to ask. So you've talked, and on your last slide that you've still got up, we talk about the breathing instructions, and when we're talking about how you asked the patients to do slow and fast inspirations, did you do, or is there a way that you can further actually quantify the speed? I know there are some tapered loading devices that have a dynamic inspiratory pressure test. I don't know if you did you quantify this, or was it purely based on instructions?
So we used the tape flow resistive loading, which is incredibly handy, because there you can see the inspiratory flow rates and the tidal volume responses. And so for the tidal volume responses, we did actually have a target. So like the first 2 breaths that you do with the tape flow resistive loading, they're against the lowest resistance, so 3 centimeters of water, kind of calibration breath. And we actually asked patients to really do their absolute best during these first 2 breaths, so that we would have the vital capacity, like an estimate of their vital capacity of the day. And we would take that as, okay, this is their vital capacity. This is 100% that they can reach today. And then during the training, so the next breaths, if patients were able to reach about 70% of that 100%, we would say, okay, this is a good resistance. If they were able to reach higher tidal volumes, we would say, okay, maybe it's too easy today, and we can actually increase the resistance a bit higher. And if it was much lower, about 50% of those first 2 breaths, we would say that we would need to decrease the resistance, because it's too difficult today for the patient. Because these patients, they change every day. So to base it on one vital capacity measurement that you maybe have taken a week ago, that does not help you out so much because it can be completely different for the patient on that specific day. So we try to quantify it based on the feedback that we had of the screen.
Okay. And that also ties into somebody else's question. You sort of touched on it, but they're asking how you found the PI max to then lead on and find the working percentage intensity. I assume it's automatic on the tapered loading devices. Or is that how you did it?
Not use the PI max assessment of the tape flow resistive loading devices because these are the standard measurements. So this is what the ATS ERS are recommending, but these are not well suited for critically ill patients because they cannot control their breathing, certainly not in the beginning. You cannot be sure that if you ask a patient to breathe out completely and then do a full inspiration, that they actually were able to do a complete expiration. So there is another method that is much more suitable for critically ill patients, and it's called the Marini method. It's already an old method. I think of 1965 it was published. Here we actually did an occlusion of 25 to 30 seconds to measure the maximal insternal muscle strength. And during those 25 to 30 seconds, patients could breathe out freely, but not breathe in. So they had a complete occlusion of the inspiration. And so by asking them to do several of these breaths, we were able to actually, with each breath, get them to a lower lung volume. So that at a lower lung volume, we can actually measure the PI max better. And then we can actually have a better estimate of their maximal insternal muscle strength without them needing to have a complete cooperation. They still need to be able to cooperate a bit because it's still kind of voluntary, but it's also pushing them, helping them to go to a lower lung volume and to get these good estimates of their maximal insternal muscle strength.
Okay, thank you. As you say, this is a very specific cohort of patients that you're using inspiratory muscle training in. Somebody has asked, or Paula has asked, if you investigated or examined the diaphragm muscle during your study at all?
During the randomized control trial, we did not. We were planning to add ultrasound assessments, but unfortunately COVID happened and we were no longer able to add it to the assessments. And yeah, so we did not assess the diaphragm specifically, but we also believe that you will have the most benefit on the extra diaphragmatic respiratory muscles. And this is also a good thing in this population because the diaphragm, it will take a bit longer to recover it completely. And you can try to bridge the gap by improving the extra diaphragmatic muscles. Because other studies have also looked into that, not a lot, but there are some evidences that we are mostly training the extra diaphragmatic muscles and not the diaphragm. So by improving the extra diaphragmatic muscle strength, we can improve the capacity of these patients and allow them to have more recovery time of the diaphragm. So what we actually do is we combine inspiratory muscle training with also these periods of, we call it endurance training, which are periods that patients are breathing spontaneously throughout the day, starting at maybe like 15 minutes, 30 minutes that they're breathing spontaneously. And this will probably train the diaphragm a bit more. But as long as you don't have the strength, you cannot continue with improving the endurance. Just like an example, if you're gonna do a marathon, it's also good that you have good muscle strength. So maybe it's also a good idea to not only go for running, but also to go to the gym and do actually some squats. And so that's how we see it. So inspiratory muscle training is a strength training that will support you to do actually the endurance and to be able to breathe spontaneously for 24 hours.
That the strength training analogy is often something that we talk about, so people understand it a little bit better. Somebody and often people bring up spirometers on these webinars. I know that Bernie Bissett has an opinion on this. Somebody has asked, would fast big breaths on an incentive spirometer be similar in terms of benefit if you didn't have an inspiratory muscle training device? Do you have an opinion?
That's very interesting. I would say in the beginning, when patients are very weak and they are unable to control their breathing, yes. Just doing fast inspirations without an IMT device will help you out. However, this will not be enough training stimulus to continue throughout the intensive care period and to really provide them with the best option, best possibilities to improve their inspiratory muscle strength. So indeed, in the beginning, the external resistance will not matter a lot, but if you see that the tidal volume does not become bigger, and you're also not the symptom scores are becoming lower, then it's time to change and to actually provide training with an IMT training device.
I think often when people think about spirometry, it has a role to play at the very beginning, even just to get people to understand that it's going to be resistance and whether it's on the in or out breath or in breath in this case. But there is no measurable or precise or kind of repeatability. And then as soon as you say, when they're showing that there is potential for training, then you can move on really to using an IMT device.
Yeah, and another actually benefit that it's hard to quantify in study results, but what we actually often saw was that when you provide an external resistance, patients will be able to breathe in deeper than when you don't have any external resistance, just because there is biofeedback that they like, okay, I cannot breathe in deep enough. Okay, I really need to do my best now and to do a full, complete inspiration. And because the tidal volume and the inspiratory flow rate are so important to get the results, this will also just, the external resistance on its own will provide biofeedback to the patients to actually do a better quality training.
Yeah, I agree. Somebody has asked, and I love this question, what happened after the study with this cohort of patients? Did they continue to use inspiratory muscle training after they left ICU and when they went home? And if so, which device, in your opinion or recommendation, would you suggest that they use?
So for this study, we stopped following them after the ICU. However, we did provide them with training clinically. So actually on our internal wards here, inspiratory muscle training is used already quite a lot. Instead of using the tape flow resistive loading, they use the threshold loading. So I would brief the physios on the wards on what kind of intensities we were training, and they would keep on training the patients. But I don't have any data on if patients actually continue training or not, which is unfortunately that's a limitation of our study. But luckily, Bernie Bissett is now doing an amazing job with a new large trial in Australia, where they are actually starting on the ICU and continuing at home. And so I hope that this study will provide more clarity on this. So the devices that we would use to go home is not a tape flow resistive loading device, just because it's too expensive to provide it to all patients. But we would use the threshold device with the smart adapters. So that's also what Bernie Bissett is now using, and really nice that we can actually have data and that patients can have data while they're training at home. Because previously, when you're only training with the threshold loading, you don't have any feedback of what you're actually doing. So it's very hard to know, am I doing a good job? What should I actually improve? It's also difficult to provide feedback to the patients on how to improve this their training and how to actually go to the next step. So this makes it much easier, and also be able to follow the patients from the hospital, and they can train from home. So yeah, I have high hopes for this study that can show a bit more long term.
As do I. I think it's both providing visual feedback, numerical feedback, and also we hypothesize and know that it helps with patient compliance when they've got that available to them. I will go back. There's a question that Vicky, I will ask it, but somebody, just because it ties in with the patient journey. So we've spoken about during ICU, we've touched on after. Somebody has asked if you were to start inspiratory muscle training earlier, before patients develop ventilator-induced diaphragm dysfunction, could this improve later weaning outcomes?
Yeah, so starting earlier during hospitalization on the ICU, it's quite difficult. So we actually try to start as early as possible. So meaning from the moment that we know that patients have weaning difficulties, we started. Training all patients that are mechanically ventilated, even while you're not sure if they have weaning difficulties or not, it's not, it's less, the research shows that it's less useful to do so, so that you would actually really need to have these patients already characterized as having weaning difficulties, and that these are the patients that will benefit the most. If you train patients who are just mechanically ventilated without us knowing if they have weaning difficulties, it will be less beneficial, and they probably can just do with early mobilization and other interventions that will also improve their respiratory muscle strength a bit.
Mm-hmm. Although that touches on, and we won't go into this, but another really promising topic, which is prehabilitation and the optimization of people before they even get to this stage. But
exactly.
That's not when they're on the ICU. And somebody has also asked, when a patient is on the spontaneous breathing setting on a ventilator, are there any parameters that you are interested in prior to starting IMT?
Of course, their respiratory stability, saturation needs to be okay. That if their respiratory rate is too high, that also already means that they cannot perform the training because they cannot control their breathing. And something that I do before actually starting training often is ask patients during the spontaneous breathing moments to follow my verbal instructions, to see if they can actually increase their tidal volume while they're breathing spontaneously. And of course, the tidal volume also tells you a lot already about their respiratory muscle conditioning. If they have really low tidal volumes of only 150 to 200 milliliters, this could be an indication that the PI max is going to be very low. It could also be related to the worse compliance, that it's a really bad compliance of the rest of the lungs. But it could provide you an indication, okay, this patient might really benefit from inspiratory muscle training if they can control their breathing. So we would sometimes come back to the same patient every day to see if they can already improve their breathing control, so that we could actually start. So that's
That feeds onto a question that somebody has asked about IMT in pediatrics. Obviously, there's many other different considerations in this cohort, but they've asked, they're doing a study on feasibility of using IMT in pediatrics when they are ventilated, but they're finding it challenging because often they're unable to follow instructions. And this Ali is asking if you've had any experience using IMT with patients who are perhaps less cooperative or less alert.
We usually stayed away a bit from patients who are really not cooperative, but indeed less cooperative or unable to control their breathing. We did have some experience with those patients, and then it's a bit a case-by-case evaluation. So I either would actually start with a low resistance to see if they can then follow my instructions, or maybe even increase the resistance higher so that they would get the biofeedback of actually trying to get the valve open. So playing a bit around with the resistance might be helpful there.
I think also, as you say, and one of the benefits of this, the device that you used in your study, the tapered loading, it comes with software. I'm not saying that this is the answer, but often having visual feedback, so you can sort of say, follow this line after you've guided them on how to do it, can help. But I imagine, I know the pediatric population can be more challenging to work with.
Yeah, but visual feedback is really we found it actually to be quite crucial to have visual feedback for these patients, so that they can relearn how to breathe. So I would think that also for pediatric populations, this could be quite beneficial, and maybe there is a possibility to even make a game out of it, so that they can, play while they're doing the training.
Yeah, absolutely. So sorry, Vicky, we're back to your question. So Vicky has asked, how did you handle any discrepancy between the percentage vital capacity achieved and the Borg rating in terms of guiding progression? So she said, if somebody reported a low Borg, but they were not achieving a high percentage of their vital capacity, would you progress or not?
I would discuss it with the patient. So if they reported low Borg scores, I would tell them, like, okay, you give quite low scores. Would that mean that you are okay with us increasing the resistance? I would try it out and see maybe that the volume actually improves. Again, with the biofeedback, it could be that the volume then actually also improves. If then the volume goes down, if it's clear that they actually cannot open the valve for more than 70% of the vital capacity, then I would say, okay, this is a more important parameter because it's an objective one that we can actually see, okay, the patient is underestimating the symptoms that they have actually, and we will decrease the resistance so that they can increase their tidal volume responses, because that's most important for qualitative training, that they are able to open the valve and keep it open for as long as possible.
I think you touched on it's often patient by patient basis and sort of adapting.
Yeah, because also the Borg scores, they're subjective, and I think everybody who has worked with this and with patients, you have patients that are completely out of breath and they give you a dyspnea score of 1 out of 10, while you actually already see that it's probably around 8 or 9, but they just are not providing a quite good answer. Or other patients that are always providing you high scores. So the symptom scores, it's a good guidance, but you have to know your patient a bit to work with it.
I guess it's where you want to compare and contrast qualitative and quantitative data. You've kind of led very nicely onto somebody asking about, and we have touched on this, the difference between the fast and the slow inspirations. Did you have a pacing guide on how many that might be per minute, for example, and how did you avoid people hyperventilating, and did they have any rests between sets?
So we asked them to do fast inspirations, but the expiration was slow and deep, which means that they have time to recover, and that also the hyperventilation becomes less of an issue. And we would allow patients to take breaks. So in general, we did actually 4 sets of 6 to 10 breaths. But it could be in some patients where we had high dyspnea scores and we could not get it down with lowering the resistance, that it was just the fact that they needed to breathe spontaneously was already enough to increase their dyspnea. We would allow them to do maybe 8 sets with fewer breaths instead of doing 8 sets of 4 breaths, for instance, instead of doing 4 sets of 8 breaths. So we would quite individualize it. so that patients would be able to
complete the training.
To do the training.
That was actually a question I had. How did you choose the protocol of the number of breath sets?
So yeah, we aimed for 32 breaths in total. So if they reach 32 breaths, we would stop the training session. But yeah, the number of sets and the amount of breaks that they would take would be individualized based on the patient's abilities.
Okay. And you can kind of up titrate as they progress.
Yeah.
The training.
Yeah. So we always try to aim for 4 sets of about 8 breaths. But it could change. But doing more than 10 breaths in a row, we have never done that with a patient on the ICU because they are too out of breath at the end of 10 breaths. Yeah.
Mm-hmm. Okay. I think there's one more question, Maureen.
Great.
Thank you. Somebody has asked about your knowledge of static compliance on a ventilator and how does this impact IMT training? C-stat.
Yeah, so the compliance, it's difficult to measure the actual compliance in these kind of patients. When they're completely sedated, we can measure it. So yeah, we have tried to assess this so that because after a while we already knew, okay, maybe the internal load would actually have an impact. So the compliance would have an impact. But yeah, it's not, if you don't measure it with a balloon catheter, you will not get the actual compliance while patients are breathing spontaneously, because you will always have the interference of actually the muscle work that they are doing. So only if they're completely sedated and the ventilator is completely taking over the breathing, then it's possible to assess this and to have a reliable measurement of the compliance. But yeah, of course, for our patients, this could be 2 months in advance that they were completely sedated, and then they were slowly waking up. So then we have data of 2 months ago, which tells us nothing about the compliance of the respiratory muscles today. So it would be interesting if there is a better way, and I think there are some studies trying to figure this out on how to assess the compliance, the static compliance in real time, even in cooperative patients. But unfortunately, yeah, we were not able to have a look at the relationship. Yeah.
And in practical terms, and we often, or I get asked this a lot, how did you, what did you have to comply with or consider with regards to infection control? You've got a device and a laptop. I mean, often it's very specific to your individual department and hospital, and they have guidelines. Is there anything that you had to do or any recommendations that you have?
Yes, so the laptop, we had to put on like something over the keyboard, on the keyboard. And we had to clean it with these very destructive wipes. So I can tell you that after the study, the computer was done. Like all the plastic, it got degraded. We used it for 3 years, so that's great. But after that, the computer, its life was done just because of all the cleaning of the computer. And then the device, itself. So you have the valve on top of it. The valve would stay with the patient, and we would clean it quite regularly, just with water in their room, and it would stay there. And then the device itself, that we would go from patient to patient, also cleaning it with the same quite destructive wipes. So also the device has seen some things. But that was enough for our
infection control department. As I say, from experience, people are able to perform IMT even on the ICU and other wards, but you just have to comply with your local infectious diseases regulations.
But I would compare it to the ultrasound device that you're bringing in, and Yeah, even the ultrasound device, I don't believe that the doctors are cleaning every single piece of the device every time. So they're cleaning the things that touches the patients for sure, but not every single piece. So yeah, it's similar to an ultrasound device that is being carried around.
I was going to say, I think you're being incredibly diligent. I remember my days on the ICU and the equipment that used to go between patients. So
Yeah.
yeah. Maureen, thank you so much for your time. Honestly, as you can see by the questions, it was a wonderfully informative presentation. I think you've opened everyone's eyes and thoughts to how they can implement IMT. And also, I'm really excited to see where this is going to go. I know you've got some projects in the pipeline, and as you've mentioned, so do people around the world. So thank you so much for your time, and look forward to speaking with you soon.
Thank you.
Thank you, Maureen. Bye.
Bye.